रिपोर्ट मेरे सामने है और मेरे मुंह में आ रहा है क्योंकि उनके हिसाब से 10 वर्ल्ड भर की बेस्ट फूडिंग्स में फिरनी और खीर भी आते हैं। वैसे इन दिनों मैंने बहुत खीर खाई भी है और मुझे बहुत पसंद है। कई सारे यंगस्टर्स को खीर इतनी पसंद है, लेकिन उसके
We will wait for another 2-3 minutes, then start.
Okay, Sanjay.
Dr. Guj, I have made you host. You can now share your PPT.
Okay. Is that visible?
Yes, yes.
Um,
I think we have around 25 people.
okay.
Yes, so I think we can start. So, hello, good evening, and welcome you all. So, for this today's the speaking Scalpel episode number 4, we have with us Dr. Goon Johri. She is a consultant oncoplastic breast surgeon at Videnshaw Hospital, Manchester NHS Trust, and she did her MCH from.
इसमें काहे नहीं आवाज आ रही है?
Hello. Okay, so she and then after that she did her fellowship in oncoplastic and reconstructive surgery from NHS Manchester itself. So I request Dr. Gunj to please start her presentation. Thank you.
Thank you, Sanjay. Thank you for inviting me. Um, I'm not sure. Are the slides moving?
No, slides are not moving.
Okay. Working now?
Yes, yes.
Okay. Great. Thank you for inviting me, and thank you to everybody who's listening. I believe it's mainly residents, so I hope it's beneficial to some of you or all of you. Um, I'll try to skip through some of the audience. He's probably Sanjay sir and Dr. Sanjay to all of you, but we were batchmates in MCH, so he's just like a family member to me. So I would continue to call you Sanjay and not say Dr. Sanjay. Um, right. Should we get straight into it? So I've tried to um, streamline the presentation, and I'll take you through it. So we'll start with a brief introduction, and I probably don't need to overemphasize the breast cancer statistics globally and in India. Um, October being the Breast Cancer Awareness Month, there is already a lot of conversation about um, the entity anyway. But we know it has replaced lung cancer, which when I was studying was meant to be the first or the most commonly diagnosed cancer globally, and breast cancer has replaced it. So nothing to be proud of, but that's the situation. One amongst 8 cancer diagnoses is breast cancer, and amongst women, it is 1 in 4 cancers that are diagnosed in women, and this is across the globe. Um, Women affected with cancer, the most commonly diagnosed cancer which affects or accounts for the disability adjusted life years is indeed breast cancer. Um, we also know, besides the increase in incidence, there is also simultaneous improvement by leaps and bounds as far as the treatment of breast cancer is concerned. So, even though the incidence or the numbers are increasing, the saving grace is that there is a lot of research going into breast cancer treatment in all aspects, whether it is the the systemic or the chemotherapy drugs, targeted treatment, and the hormonal treatment as well. So there is the good and bad when it comes to breast cancer. Um, in 1970s, they said 4 in 10 women diagnosed with breast cancer survived their disease beyond 10 years, but now it's around 8 in 10. So that only goes to show that even though the incidence is increasing, the survival or the patients are living longer and surviving the disease, which makes one reflect that there is even more need to give them a better quality of life, because it's no longer 5 years since your diagnosis that you expect the patients to do well, and then you don't really look back at them after that. Nowadays, women survive longer and deserve a better quality of life. Um, when we come to our country, it's more than 50% of Indian women suffer from stage 3 and stage 4. So, unlike where I work currently, where so UK has a national screening program and they pick up a lot of screen detected or very early breast cancer, which is not symptomatic and only picked up on mammograms. Um, we all know it's a completely different ball game back home, and most of our patients come with locally advanced disease. Again, even though the incidence of breast cancer in India, if you compare with the West, and with that I mean US or the UK incidence, would be lower, but the survival, unfortunately, is poorer as compared to the developed countries. So the topic that we wanted to discuss today was evolution of breast cancer surgery. So I'll not dwell into other territories of breast cancer management. We'll stick to how the surgical treatment of breast cancer has evolved and is continuing to evolve. And probably a lot of you have already seen this picture. It's a very commonly shown picture in most presentations. It's taken from the Egyptian papyrus, which is the earliest mention of the term breast surgery and dates to 1500 BC. So that's the earliest mention of breast cancer surgery. And it evolved over years from the era or the Middle Ages where surgeons were termed barbaric surgeons, and where instruments like these, it looks like a guillotine, like we use for amputations, were literally used to chop the breast off and treat breast cancer. And this, as one would understand, was inhumane, resulted in a lot of complications, blood loss, and even death. And then further down the line, there were improvements, and then came the Hallstadian era. But before this, there was a French surgeon called Jean-Louis, who spoke about radical mastectomy, but it was Halsted who first published it and spoke about it or printed it. And that's the importance of publication way back in 1882. So he gets the fame for it, whereas this Italian person who actually recommended doing this operation and saved a lot of women from having this procedure is just an anecdotal mention. So coming to William Halsted, he was a very he was a pioneering surgeon at the time, and he realized that we can probably do less than what we're doing in terms of breast cancer surgery, and he devised an operation called radical mastectomy, which now is anecdotal or historical. And you're probably all aware. So he did a very aggressive surgery, so radical surgery, removed the breast with the pec major, all the lymphatic tissue went right up to the supraclavicular area, and closed the defect with a skin graft. It was an improvement from what was going on, and at that time, even the 40% cure rate was considered a good cure rate. He constantly improved his practice, so he introduced the antiseptic technique in surgery after Joseph Lister's discovery, and even invented the rubber gloves that we use now, which I don't know if a lot of you know or not, was for his wife, who was his scrub nurse, who had dermatitis, to washing the soap that they used to wash. And because she had dermatitis, he asked the company who makes rubber tires if they could make rubber gloves for his wife. And that's how the gloves we use today came into practice. So anyway, to cut the long story short, until 1964, 90% of the surgeons were following the Hallstadian mastectomy. But then came Robert Patty, who was a surgeon in London in the Middlesex Hospital, and he felt it was too aggressive an operation, and he started leaving the pec major behind and just removing the breast and the lymphatic tissue. They still continued to use the skin graft to cover the defect, but the morbidity was much less. And of course, I'm sure as general surgery residents, you do get asked, and you do read about the types of mastectomy and what is modified patties and what is modified radical mastectomy and the types. So I don't want to educate you on the modifications, but I think in your exam you're expected to answer the Madden Scanlon modification and the patties mastectomy. But we leave it at that and see how we evolved from the mastectomy era or the radical mastectomy era to less than radical mastectomy. So just to summarize, so we spoke about radical mastectomy, and then the shift towards less than radical came from Patty, and then it was this very illustrious surgeon scientist, Bernard Fisher, who is an American surgeon, and he wanted to determine the outcomes between radical and less than radical mastectomy, and he devised a randomized control trial, which is a landmark trial in breast cancer surgery, is the NSABP 04 study. It was basically set up as two parallel trials with node positive and node negative breast cancer patients, and their 10-year follow-up when they compared radical versus total mastectomy with radiation or without radiation, they found that there was no difference in the disease-free survival, recurrence-free survival, and the overall survival. And 25 years down the line, 2002, they came up with the long-term outcomes, which was 25-year outcomes. And it again reinforced the same thing. Of course, by 2002, things had changed because it was not only this study, it was a lot of trials that were happening in tandem, and world over, there was a significant shift towards lesser mastectomy, or what you and I study as modified radical mastectomy. Of course, with general surgery, you first learn open surgery and then you move to laparoscopic surgery. And the same happens in every field, whether it's thyroid surgery or even breast surgery. So once mastectomy was established, or a simple mastectomy with axillary surgery was considered good enough than a radical mastectomy, people started contemplating whether it is possible to save the breast at all and not remove it for a tiny cancer. And these were all the clinical trials that were happening in tandem. So the significant ones to quote will be the Milan study and the NSABP 06 and the EORTC. I'm not going into the details, so please don't worry or try to read this table, but I'll just mention the Veronese trial or the Milan trial, which we popularly or commonly read as quad therapy or quadrantectomy with radiotherapy. And this was an expected answer when we were studying general surgery, when breast conserving surgery was just starting to come into the surgical handbook of people who were practicing breast surgery. So as a part of the Milan trial, they tried to compare mastectomy with breast conserving surgery. So just be careful there. So they were comparing radical mastectomy with breast conserving surgeries. This is the time when they were still practicing Halstedian mastectomy in the 1970s. And again, multicenter trial. Again, they restricted themselves to 2 centimeter tumors or a T1 cancer and N0. Again, there is a lot of criticism as to who decided 2 centimeters, how did they measure it, how were the margins assessed, and things like that. But the bottom line is the long-term follow-up or the 20-year follow-up of this study has also shown that in early breast cancer or T1 breast cancer, a lumpectomy with radiation treatment is not inferior to a mastectomy, and therefore it then became the treatment of choice for women with small breast cancers or relatively small breast cancer. So now the term relatively small breast cancer is the catchphrase here, but also bear in mind that the the local recurrence in this study for breast conservation was higher in the breast conserving group. So over time, it was well established, based on the Milan trial and several others along with it, that for early breast cancer, we are safe to say that the outcomes are comparable. But we always used to, when we used to consent patients, we used to always say, but there is a risk of local recurrence being slightly higher than a mastectomy. And the difference is not much. We were told the magic number of 1% with a mastectomy and 3 to 4% with a breast conserving surgery, but it doesn't impact your overall survival. And this came later, uh, based on many studies, but it was this study from Denmark by the Danish group, which is a landmark study, which established that the overall survival and the quality of life was superior in breast conserving surgery as compared to mastectomy. I think this was one of the first papers that came out and said that the survival in breast conserving surgery, which is the top line or the red line, versus the mastectomy. So you see the survival is lower in the mastectomy group. And after that, there have been many other such publications, this being the most recent and was only circulated, I think, a few weeks back. Again, outlining that breast conserving surgery is associated with improved survival. So this is something we never told the patient, or we never said as a part of consent that you will have better survival or improved survival with breast conservation. So it is absolutely safe now to tell the patient with early breast cancer that it is safe and better for you to have breast conserving surgery. But one would think, why is this happening? Why is breast conserving surgery better, or as compared to a mastectomy? It doesn't make sense. So there is no proven factor. This is obviously what the studies has shown, but if you see scientifically or on the pathological or pathogenesis of it, is one of the theories is that mastectomy is a bigger surgical insult, causes more generation of more inflammatory markers in the body. It takes longer for the body to recover from the inflammation or the inflammatory mediators generated by a mastectomy as compared to a lumpectomy, which is a very small procedure or a minor insult to the body. And because of that, the mastectomy procedure in general systemically lowers the immune system, and it gives the cancer cells or the microscopic cancer cells in the body to dominate and metastasize or lodge in other areas and cause local or systemic recurrence as compared to a breast conserving surgery. So that's one of the theories that's behind this, or explains it. Right. So just to summarize, we came from mastectomy to quadrantectomy to a small wide local excision or a lumpectomy or the breast conserving surgery that we now know of. The quadrantectomy, as the word says, or which Milan trial recommended, was removal of one quadrant, but we know that we no longer need such wide margins around the cancer lump. You just need a clear 1 millimeter microscopic and 1 centimeter macroscopic margin around the tumor. Right. So from 1998, when we were in the era of 70% of breast cancer patients undergoing mastectomy, to 2004, after the trials, it's 38% mastectomy. So that's an improvement. There are, of course, the standard answers that you're expected to give in the exam. of what is the absolute indication for a mastectomy. And previously, it used to be 4 or 5 centimeter tumors or anything above T2, but that is debatable. Now, multifocal breast cancers, still a large majority would undergo a mastectomy. Patient choice, of course, and inflammatory breast cancer, um, again, is one of the reasons. So, moving towards the second most recent evolution being breast conserving surgery, and we've already talked through some of it. So, it can range from a simple wide local excision. So, again, breast conserving surgery does not imply a fancy incision or a complicated dissection or somehow conserving the breast. It can be as simple as one cut on the breast, one cut on the armpit for the sentinel node or the axillary clearance, whatever you're doing. And it can be as simple as that. And it all depends on the location of the tumor, the breast volume that we're dealing with. And it can be as simple as this simple cut on the skin. It has healed beautifully. The patient is happy, nothing complex surgery wise, and it's a 60-minute procedure because she only had a sentinel lymph node biopsy and a simple wide local excision. So, breast conserving surgery does not mean oncoplasty and does not mean a fancy incision. The second stage of it would be where you have to move things around a little in the breast, but it is just the surrounding breast tissue, and it's called volume displacement, where you're just using the surrounding tissue to fill the gap. And the more complex procedure, of course, is volume replacement, where you're bringing volume from the surrounding tissue but outside of the breast and readjusting it to fill the defect that you've created from the lumpectomy. And we'll talk more about it. If any of you have any questions until now or in between, please feel free to put your hands up and I can take questions in between or at any time at the end. Right. So, textbook answer for indications for breast conserving surgery, and these are the exam answers. You would say early breast cancer, stage 1 or 2, and stage 0. Obviously, if it is DCIS, you can do a lumpectomy of just the area of DCIS if diagnosed preoperatively. So small tumor size, and usually we say less than 4 centimeters and confined to one area of the breast. So multicentric tumors, no, and multifocal tumors also, you would think, if it is possible to do that. And we'll talk about that more. Obviously, you would want clear margins, and the way to ensure margins is either you have a frozen section in the theater or you do imprint cytology, and there are many other fancy techniques which we will not go into because they are not available in most places. And what we follow here in the UK, we don't have the luxury for a frozen section or a pathologist in the theater or near the theater complex, just because of the sheer volume of breast cancer cases because of the national screening program. So we just consent the patients for a lumpectomy with a risk of coming back for a second operation if the margins are close or positive. And that's how it is. And the return to theater rate is at an average about 10 to 12% across the country. So 10 to 12% patients come back to get margins cleared. The other indication for breast conserving surgery would be obviously a favorable tumor location, so an upper outer lump or a lower lump, which you can easily get from a neat incision, and you don't need to do anything fancy, would be the ideal for a breast conserving surgery. And obviously, patient willing to undergo breast conservation with no contraindications to radiation, which brings us to the contraindications. And we'll go through the conventional ones before. So initially we used to say large tumors more than 5 centimeters, but I would no longer put this as an absolute contraindication for breast conservation, and we'll know why. Again, multiple tumors is not a contraindication for breast conservation because two lumps close by next to each other in the same quadrant can be easily removed with breast conservation if you have enough tissue to remodel the rest of the breast, or you can bring in some tissue from the outside and replace it. So again, multiple tumors. Some surgeons even do two quadrant if they're in two different quadrants, but tiny cancers in opposite quadrants. You can still do a breast conservation if you have clear margins. Locally advanced breast cancer, with the neoadjuvant chemotherapy that we have today, it is possible to downstage the tumor and do a breast conserving surgery. And of course, inability to clear margins. So we've had patients who've had 3-time re-excisions but one breast conservation, and it clears it the third or the fourth time, and they don't have a mastectomy. So the absolute contraindication for breast conserving surgery, I think, would be early pregnancy. If the patient is undergoing surgery in very early pregnancy, you wouldn't be able to radiate if the pregnancy is continuing to term. And that would be a contraindication. Even with collagen vascular diseases like rheumatoid arthritis, SLE, if it is well controlled, most radiologists or radiation oncologists would be happy to radiate the breast, but it has to be a discussion with your team and with the oncologist. Prior radiation therapy is an absolute contraindication for breast conserving surgery because they're not happy to radiate the skin again, obviously with the risk of damage to the underlying structures and second malignancies, and just poor wound healing. A patient who's had breast conservation and has a recurrence usually would land up with a mastectomy. Okay. So I think it is safe to say, and I hope all of you agree with me, that today's day and age, the standard of care for early breast cancer would be breast surgery, and few cases of locally advanced breast cancer that respond well to chemotherapy would be suitable candidates for breast conservation as well. And we can either keep things simple, just do a simple wide local excision, but gone are the days. So initially or traditionally, when breast conserving surgery was just coming in, we were told we just get the lump out and then a seroma will fill the cavity and give the contour or shape to the breast because the fluid fills up over there and gives the cosmesis. But gradually with time, people realize that that is temporary and eventually the seroma will get absorbed, and then the patient would be left with a defect with just skin and a cavity underneath it, and the rest of the breast tissue has frozen or fixed because of the radiation that she's received after her surgery. So ultimately the skin would go and adhere to the chest wall and result in very unacceptable deformity. So we can no longer leave the cavity as it is in the name of breast conserving surgery. So we needed to evolve from there as well. And that's when the role of oncoplastic breast surgery came in. So as you see, this is all evolution. When we started breast conserving surgery, that seemed like the best thing after a modified radical mastectomy. But we soon realized that this is what was happening. So initial post-op outcome would be something like the picture I showed you. Everything looks nice, and because it's the seroma that's keeping the skin away from the chest wall. But eventually, after radiation, these are the appearances that the women came with. And because most of these women had early breast cancer, they would live longer, they would survive the 10 years, but they would hate the way they looked. And that's when oncoplastic came in. Also, with better survival in general, better quality of life, the population is growing and living longer. So there is the population living until 60, 70 years, 80 years is increasing. And this is the age group that is conventionally the age group that you expect breast cancer to occur in. Of course, we're not going to discuss the early, a lot of patients coming now with early breast cancer and 30-year-olds and 25-year-olds. But the longevity is increasing. There's also a global pandemic of obesity going on. So with the increasing lifespan, obesity is also increasing. So it was noticed that the breast volume in general is also increasing. So the average breast volume is increasing, age is increasing, and of course, nobody wants to look like this after breast surgery. So oncoplastic breast surgery came into being, and you probably already know oncoplastic breast surgery, basically, as the name suggests, is the combination of oncological clearance with good aesthetic outcome. Sorry, I was just checking the time and making sure I'm not overshooting. So traditionally, we would classify oncoplastic breast surgery into two types, and this is based on the Krishnaklov classification. It might be worth reading about this surgeon as well. So he's an Italian surgeon, and he's considered the father of oncoplastic breast surgery. So level 1 is where less than 20% of the breast volume is excised. So it includes a wide local excision and simple tissue approximation, or what we said earlier as volume displacement, or moving the surrounding breast tissue and using it to fill the gap that you've created with your lumpectomy. Again, this is probably the workhorse of oncoplastic breast surgery, because most surgeons, and you don't have to be a trained a trained breast surgeon or a specialist to or a subspecialized surgeon to learn this technique. If you've seen a few, it should be very easy for any surgeon to incorporate this in their practice. Level 2 is where 20%, more than 20% of breast volume and up to 50% of breast volume is expected to be excised. So we're talking bigger lumps in either moderate or smaller breast volume. And then is the role of mammoplasty or therapeutic mammoplasty or volume replacement using flaps. And this would need some training even for subspecialized surgeons, and you need more numbers and you need to be doing these cases more frequently. Now, of course, one can ask, how do you measure 20% and how do you measure 50% of breast volume? It is eyeballing. You have to make a judgment based on your experience, the tumor size that you see or feel, and the breast volume that you are given or the patient has. Sorry. The principles of oncoplastic breast surgery are very similar to the principles of breast conserving surgery. So I've just clubbed them here. So you would excise the tumor with a wide margin, as we would normally do. In this, the skin incision, or the intention is to use an aesthetic skin incision. Again, that does not mean that you cannot use the incision that I showed previously in the picture. It should just be an incision that heals well, is likely to scar well, is either along the lines or the skin crease, or it could be a periareolar or an intramammary incision, which usually merges with the natural pigmentation, or an inframammary incision, which is not seen at all if the lady is stood up or sat up. So you would raise the flaps like you would in a mastectomy, and you would undermine more than you would do in a simple wide local excision. So if you're doing a simple breast conserving surgery, you would just undermine the local flap locally over the lump, take the lump out and close the skin. Whereas in oncoplastic breast surgery, you want to mobilize more than you intend to remove, because the intention is to bring together all this mobilized tissue into the cavity that you have created. So you may have to undermine the nipple, you may have to underline the areola, and it is all right to do that, because you're intending to move things around and readjust them in a way that at the end of the surgery, it looks like a breast, and it has the contour and the aesthetics of a breast and the volume of a breast. So you want to mobilize the breast parenchyma off the chest wall and on the skin. So you're undermining in dual plane. You undermine the skin and you undermine the breast tissue off the chest wall as well, so that the breast gland or the breast tissue is mobile enough for you to move around into the cavity. And then you either fill the defect by this displaced tissue, or you replace tissue from the surrounding. Obviously, you will assess the margin, and if you're not sure of the margin, you come back for a second procedure, and which is a two-stage procedure, and I'll talk about that later. Now, because we are doing so much on one breast, which is the cancer breast, it may turn out that the other breast looks different or asymmetrical as compared to this breast. And a lot of patients come back and say, I like the one that you've operated more than my original breast because this one's larger, difficult to manage. I'd rather have a smaller breast, which is easy to manage and better for me. So you may have to symmetrize the opposite breast. Now, I'm aware because I've practiced in India for the longest time. So I'm aware that a lot of ladies would not relate to this school of thought and would be fine with whatever job we do. But there will be a set of patients or a set of your clients who would say that I'd like to be matched and I'd like to be symmetrical. And of course, you would need radiation like you would need after breast conservation. In fact, a lot of oncologists feel with breast reduction as a part of oncoplastic breast surgery, the dose of radiation delivered to the patient is smaller, better targeted, so it improves the radiation delivery from the oncology point of view as well. And it's lesser side effects of the radiation because you need a smaller dose for a smaller and reduced breast. Okay, so very quickly, this is volume displacement and probably the simplest or the type 1 kind of oncoplastic procedure. So the cut, again, you see, when I mean an aesthetic scar, that doesn't mean it has to be a hidden scar or it is just has to be a strategically placed scar, which you think will heal well and look nice on the breast or as nice as it can. So that's the cancer lump. You've taken the lump out, and this is in the yellow is the surrounding breast tissue. You can see the chest wall in the pink, and that's the site of the cancer. So you mobilized this tissue. That's where the lump was. You mobilized the surrounding tissue, and you've closed the tissue in and then closed the skin on top. You see the division or the closure on the tissue is different from the closure on the skin. Also, if you notice, the undermining or the undermined area is much larger as compared to the tiny lump that you're removing. And the intention is to mobilize the tissue between the skin and the chest wall, which is your breast gland, as much as possible so that you can fill the defect. And you would get a scar or an outcome like I showed in the picture before. These are slightly more, so they look complex and they have fancy names, but essentially, if you've seen a few procedures or if you've read about a few procedures, you should be all right practicing most of these procedures, and they're not difficult to practice. A lot of surgeons use round block technique. A round block essentially means you're going all around the areola. So it's a circumareolar incision, and it can either be a single incision or you can do it in two rings like a donut and take the skin intervening off. You get more room by doing that. Lift the skin off like you would, and with a round block, a lot of surgeons like it because you can literally go in any quadrant. If you see this picture, every quadrant has a round block mentioned in it. So you can access a lump in any area of the breast if you know how to do the round block technique. So you don't even want to know the other fancy procedures. If you know the round block technique well, and if you get good planes in the skin and good planes on the chest wall, you can access any lump. Now, there are other specific procedures like the Grissotti, which is specifically for a central quadrant lump or a central lump, where you remove the central lump and you bring this tissue up in place of the nipple areola and create a new one by using this skin at the bottom. You would understand that the breast would be reduced because you've taken the central bit and pushed this tissue in the middle. And there's other procedures like the Batwing procedure, again, that can access the upper quadrant tumors or the central tumors, and other techniques. So these are the other incisions that one has shown. But as I said, this is a modification of the round block. So if you've something here, you extend your round block like this, lift up all the skin, lift up the breast from the chest wall, do the lumpectomy and close the defect. You can imagine this would move the nipple up slightly, and that's where the discussion about symmetrizing or lifting the other breast might come in. The choice of procedure would depend on these factors: the patient body habitus, the BMI, size of breast volume, the ptosis of the breast volume, is it grade 1, 2, or 3, and then the location of the lump and the breast tumor ratio at the end of it. So I won't go into the details of all these procedures in the interest of time, but I'm happy to take any questions if you'd like. Just to bear in mind the indications for a therapeutic mammoplasty. Now, this is the type 2 oncoplasty territory where we are either replacing or moving tissue around in the breast or from the surrounding to cover the defect that you've created by lumpectomy. So again, this is used when you have large breast with ptosis that need reducing, and results in cosmetic improvement, might cause asymmetry if you're just doing one breast at a time. So a large tumor in a large breast, this is the ideal situation where you can use these techniques. Again, multifocal tumors, so 2 lumps in the same quadrant, you can just remove 1/4 of the breast and use the rest of the breast tissue to remodel and shape it into a proper looking breast. And I've mentioned the reduced radiotherapy damage as a result of this. Most importantly, you can avoid mastectomy. Multifocality used to be the box standard indication for a mastectomy, and with these surgeries, you can avoid doing a mastectomy. So what I would encourage you to do is, with every case or every patient of breast cancer that you see, look at the tumor size, breast volume, and think, is it conservable before thinking of a mastectomy? I think that's how we need to train our minds. So this is a lady who had cancer on the right side, and she had a therapeutic mammoplasty. So you can't see the incision completely, but this is a vertical incision or similar to this one. So she had a cancer here, and this is the incision that has been used, but the nipple was involved. So that has gone off, and she's had this procedure, but she's come back saying she doesn't like the discrepancy in the size and she'd like her opposite breast to be matched to the cancer side. So she's had a reduction on this side, which is, again, the scar is slightly different. So if you see, this is a anchor shaped scar on the left side, whereas this is a vertical scar on the right side. And on this side, she's had a nipple reconstruction and a tattoo for the nipple. And that's the outcome for a mammoplasty. So again, if you notice, this is 20%, more than 20% of the breast volume gone. And that's why we needed type 2 here. So when we talk about mammoplasty, we talk about pedicles, and that depends on the location of the tumor. When I say pedicle, I mean the blood supply to the nipple areola, because if you're doing a breast conserving surgery, the idea is to retain a breast looking structure at the end of the operation, and you don't want the nipple areola dying or turning black after you have undermined this whole area. So the pedicle is what determines that this lives after you've done the surgery. surgery. And so inferior pedicle is ideal for a superior quadrant lump, where you can take the lump out and the nipple areola survives on the inferior pole tissue, and the blood supply is from there. Again, with the inferior pedicle, you can access lumps in any of these areas and just transpose and move this whole tissue into this defect that you've created, and you would end up in anchor-shaped scars or inverted T scars. All these procedures have complications, but I won't go into the details of that. But most important, most dreaded would be nipple necrosis or nipple loss, fat necrosis, and things like that. Again, superomedial pedicle, you would imagine would be for a lower quadrant or a lower outer lump or an outer quadrant lump, where literally you can sacrifice this breast, this outer half of the breast, and swing this tissue into this defect to result in something like this. So a smaller breast, this was the cancer area, and the nipple areola survives on the superomedial tissue. So this is the superomedial pedicle, or the tissue which makes or retains the blood supply for the nipple areola, and you can access lumps anywhere in this territory. Get this tissue out, swing this tissue up, and you get a smaller and uplifted breast. So again, this is a very handy procedure, and again, you don't need to be very highly trained for this. It's called the melon slice. It's very easy. You don't have to go anywhere near the nipple areola, don't have to undermine anything. If there is a very elderly lady who has a very large volume breast and a lower quadrant tumor over there, you can just remove this slice of tissue like here and just close it horizontally, and that's a melon slice procedure. So that was volume displacement, level 1 and level 2, or therapeutic mammoplasty. And then we come to volume replacement. I'll run through it very quickly, just in the interest of time. I'm hoping some of you have seen local perforator flaps, because I'm aware Sanjay and his colleagues are also doing it there. So these are basically perforator flaps, which are based on perforator vessels in the surrounding of the breast tissue. So it can be in the inferior mammary region, it can be in the lateral chest wall area. And basically, the intention of these flaps is to allow us to excise bigger tumors in smaller breasts, and replace the volume with surrounding tissue. Otherwise, these patients would just end up in a mastectomy, because there's not enough breast tissue to leave behind if you do a simple wide local, and there's not enough room to do a therapeutic mammoplasty because there's no breast volume to replace the lumpectomy. So the breast tumor ratio, or the tumor breast ratio, is more than 20%, and these can be 1 stage or 2 stage because you want to be sure of the margins. Again, they look complicated procedures, but they are simple once you've done a few. They're not difficult to master or practice, and they result in very good aesthetic outcomes. So why do we need these local flaps? So again, small breast volume. This has been removed, but nothing to replace. And after radiation, this is what has happened. This is called a parrot beak deformity. And even in good volume breast, this is what has happened because of the radiation. And these can be helped with a local perforator flap. So very briefly, they can either be the lateral intercostal artery perforator flap, medial intercostal artery perforator flap, or the MI cap, and the anterior intercostal or the AI cap. There are others as well, like the lateral thoracic artery, LTAP, and the TDAP, thoracodorsal artery perforator flap. I won't go into the details of that, but these are mainly, if you see the location, the higher you go, the more tissue you can get and replace. So the local flaps, the AI cap, MI cap, and the LI cap, are relatively fixed tissue flaps where you get limited amount of tissue to replace the cavity. But with the LTAP and the TDAP flaps, you have more, you can be more bold with your excisions, and get more tissue from the back and the chest wall to replace. So a lot of people think you need special equipment for the perforator flaps. I would only use the Doppler, but a lot of my colleagues use the loop as well, and it does help. I think I'm still banking on my eyesight, but maybe a few years down the line, I will start needing the loops as well. So these are the markings, and this is the usual site for the LICAP perforator, which is between the fifth and the sixth lateral intercostal perforator, and it lies within a centimeter, within 2 centimeters of the lateral border of the breast and the anterior axillary line. So this is the area where you get the LICAP perforators, and these are the TDAP and the LTAP perforators, which are less constant, unlike the LICAP. As I said, it is a more fixed perforator. So this patient, as you can see, she has two site-wide two wires going in, and this whole area has to be removed. And but another senior colleague of mine, so she's marked the possible perforators, but the one that was used was a TDAP flap, but because you can see it's a very large area in a very small breast, so we use this whole paddle of tissue and flopped it back into the breast cavity. So very quickly, that was the LICAP flap. Now this is a different patient. She's having a LICAP flap. That's the perforator's pre-op marking, and this is the lateral border of the breast. That's the flap, and through this incision, you remove the sorry. So that's the flap, and this is how it is raised. This is just the lateral tissue, and these are the perforator vessels. So that's the LICAP, that's the LTAP. So if you need this whole tissue, you can sacrifice the LTAP. If you've got a good LICAP vessel, that's enough to for the tissue to survive. That's the lumpectomy cavity from the lateral view. So that's the lumpectomy. That's the skin flap. Lumpectomy has been done. And now you just take the skin off from the flap tissue and turn it into the lumpectomy cavity. So that chest wall closes. This is the lateral chest wall. It just closes. And this is the flap that's gone into the breast. And that's how it looks after closure. I'll skip the video, and these are the type of, the way you can flip the tissue. So you can either turn it over. This is the most commonly done. So it can either be a turnover LICAP or a propeller where you swing the tissue on the pedicle. You obviously would compromise the pedicle to almost 180 degrees in this procedure, and you need to have a good, robust, good pedicle. And the transposition is just like if you've seen any LD flaps where you dissect the tissue on the pedicle and then transpose it into the cavity. Usually you would need an LTAP or a TDAP flap. LICAP flaps are smaller and not very suitable for transposition, but any local flap can either be a transposition, propeller, or a turnover flap, the turnover being the most common. So again, benefits of doing one stage procedure: it's one operation for the patient, reduces operating time, and but the downside is it's a large tumor in a small breast. You are likely to be miser with your margins if you know you are doing it one stage, and the patient might come back for a re-excision. If you do a two-stage, you get the opportunity to confirm the margin status, confirm the nodes, and you don't waste any local flap. You can do it in the second stage once you're sure that the margins have been safely cleared. So it's a safer option, and we are recommended to start with a two-stage procedure if you're starting to do local flaps. So these are just some outcomes of local flaps. So she had a wide local and then a second stage perforator flap. And that's the outcome after the surgery from the front side, and that's the scar. And this is a delayed LICAP. So this is a lady who was very unhappy with her. She had a simple wide local, but this is what had happened to the scar, and she didn't like it at all. So she had a local perforator flap, which took care of this deformity, and obviously she was very happy after that. what would you do in this lady? So very small breast volume. She has, you can see a visible puckering of the skin. So the skin is involved. It's a lower inner quadrant IMF area, um, 15 millimeter, but small breast. She had very dense breast volume, so we did an MRI which showed a 43 millimeter. So it's a 43 millimeter tumor in possibly an A or B cup breast. So she ended up having an AI cap with a wide local. So that's the planning for her. And because we were excising the skin, we use some of the flap skin to rotate it into. So that's the Doppler checking the perforator or the anterior perforator. And that's the perforator being shown by the forceps. And that's the skin being rotated into the defect because we've excised skin. And that's the outcome. So that's the AI cap or the MI cap. And these are delayed AI caps for similar deformities or late deformities that patients are not happy with. So this graph is very commonly used where you have the breast size or the breast volume and the type of breast conserving surgery or oncoplasty that we recommend. So smaller breast, you would need volume replacement. Larger breast volume, you can either do a simple wide local or you can do therapeutic mammoplasty. Very large breast ptosis, you are in the territory of therapeutic mammoplasty. This is a very good reference chart, which is very commonly shown in conferences as well. But very good reference guide. If you're not very good with eyeballing, this is a very good chart to follow. Right. Last but not the least, there is something called lipomodeling or fat grafting, where we can harvest fat from the abdomen, thighs, back, or usual sites of liposuction and purify the fat and inject it underneath the skin. So this is a lady who had a simple wide local and after radiation had this indentation. Fat was injected and that has leveled it. Again, this is not permanent, so you would need multiple sittings because the fat eventually dies off and then they come back again and have further sittings. But it's a good solution to replace the volume without doing any fancy procedure. And again, this technique, if you learn once or twice, it's easy to practice in your day-to-day practice. I'll just conclude very quickly. I'm sure we don't have enough time left, so I'll just conclude that we are currently in the time of de-escalation where less is considered more. So we are moving more towards uh, sentinel lymph node biopsy even after chemotherapy. I won't mention or go into details of the study, but the Sentinel study, the SNFNAC study, and the ongoing ATNEC trial, which is looking at trying to reduce the rates of axillary lymph node clearance in patients who had positive axillary lymph nodes but had neoadjuvant chemotherapy and complete response. They are being randomized to sentinel lymph node biopsy, um, um, and then depending on that into axillary clearance versus no axillary clearance group. So there is de-escalation in all fields. Even with surgery, I'm sure there will come a time where we will say after chemotherapy it is all right to just monitor the patients and not do any surgery if there is complete radiological response. There is an ongoing trial called the small study where any tumor grade 1 less than 15 millimeters, ER positive, HER2 negative, they are being randomized into wide local sentinel lymph node biopsy versus just a vacuum biopsy with no sentinel lymph node procedure. So that's another de-escalation for very early breast cancer. And this is again what I was mentioning. So dual anti-HER2 for HER2 positive patients, neoadjuvant chemotherapy. If there is complete radiological response, they're just doing ultrasound course to confirm that there is pathological complete response and not operating on these patients. So this is a feasibility study or the Nostra study. So I think the role of breast surgeon is also changing with more and more towards breast conserving surgery, and thinking on those lines. Um, yeah, I think I will just conclude with that. I think we are moving towards less surgery, less chemotherapy, less radiation, and less hormonal treatment. Um, Thank you for your patient hearing. This is where I work in Manchester. That's the Withenshaw Hospital, and that's my team. Yeah, thank you. I'm happy to take any questions.
Thank you, Gunj,
Thanks, Sanjay.
for excellent talk. And
Pleasure.
so our moderator, Dr. Arpan Mishra sir, has joined. I will
Hello, sir.
request him to, yes, please give his comments and start the discussion.
Okay, good evening, Sanjay. Good evening, Dr. Gunj. It
Good evening,
was
sir.
really a very good presentation.
Thank
You
you, sir.
included almost every aspect of the oncoplasty in greater details.
Thank
Now,
you.
I'm almost 10 years elder to Sanjay, and I am surgical oncologist.
Yes,
And
sir.
since Sanjay has joined, a lot of things have changed in the management of the breast cancer.
That's very
So
good.
what I feel here is, I must
Yes.
say that there are two hurdles in breast conserving surgery and mammoplasty in India. One is the delayed presentation of the patients, and the
Yes.
second is the mindset of the surgeons. We are not ready to accept that the breast can be preserved or the 1 millimeter margin is sufficient. I
Mm.
think you must agree with this. When you were working in SGPGI, there
Of
there are
course.
there are people that those who don't accept that 1 millimeter margin is sufficient, which is
Yeah.
scientifically proven in many studies.
Of course. Yes.
So these are two major hurdles. Those really make us difficult to think about doing oncoplastic surgery. And second issue is breast is a three-dimensional structure which requires really a kind of reconstruction which is required for three-dimensional thing. So most of us are trained in reconstructing two-dimensional things. So
Yes.
breast is a 3D structure. So oncoplasty is a different technique which requires practice and which requires special training. It's not just removing the lump and closing the structure, so then that
No.
would not a good cosmetic result. So you have very well shown all those things. I'm sure that every listener in this must be benefited with this, and it's a really good talk. I enjoyed.
Thank you, sir. Thank you. It means a lot. I agree. I've worked in I've trained in 3 different hospitals in the country, and I've worked in again at least 3 or 4 institutes at different stages after general surgery and after specialization. Um, both the points you made are absolutely well taken, and I agree with it. But I think it boils down to experts like yourself and now Sanjay as well, who's an addition to your team. I think it is up to us to sort of propagate and because you being senior to us, patients associate a sense of credibility to you. So I think if it comes from senior surgeons, senior consultants, and if you would go and teach, or if Sanjay goes and teaches in other forums, I think it's a case of unlearning for a lot of us. A lot of things I've had to unlearn after coming here, and it's only been 2.5, 3 years in UK. So I think it's a case of evolving for us as well. We need to evolve as well, and I think if more and more surgeons and specialists talk about breast conserving surgery, um, I think it will drive the point home. But we can't really. I think the root cause is the late presentation. Um, I see a lot of awareness happening about breast cancer even in the last 5 years, I remember when I was in general surgery, I used to run a breast clinic in the general surgery department and give talks on breast cancer awareness. But now it's come in a big way in the country, and I see almost everybody, especially in October, it's very heavily discussed. So I think we need to make the most of such opportunities and spread as much awareness among the general population, um, down to the villages, that this needs to be taken seriously. Um, I know from the Indian point of view, breast screening may not be that practically feasible or cost effective, and that's where the role of breast examination, especially I've seen some studies just to prepare for this talk, where the ashas and the health workers have gone into the rural areas and the tribal areas, and they've been taught breast examination. They've examined ladies in the interiors, and that has shown improvement in detection, diagnosis, and survival. So that's very promising. I think those are the areas we need to work at. Uh, India is huge, so it'll take another few decades to get there. But I think we have to keep trying and keep emphasizing that it is safe. And I think more local studies, I think no better person than Sanjay to publish and print um, print papers. So I think more local data is needed, especially in India. More authentic data is needed to prove that what we are saying and believing is actually true.
Very rightly said. I often say to many of the patients, those who say that why lumpectomy, why not mastectomy,
Yes.
or to the surgeons. So
Mhm.
when I say this, if I say like if there's a cancer in one of the fingers, will you go for the disarticulation from
Yes.
the
Oh,
shoulder? So it's
that's an
like
amazing
almost
example.
similar thing.
Yes. Yes.
So I agree, and I
Yeah.
hope that in next decade we will see that more and more patients, there is breast conservation going on, and reconstruction and oncoplasty will take a good shape in India. I think I will hope so.
Hopefully, sir. Hopefully, I think so. And you've given an amazing analogy to the patient. So that is what we need to learn from seniors like you, how to, drive the message home. So that's an excellent example. I think I'll also use it. So yeah,
So now,
thank you.
if there are any questions from our residents, I'm sure that Sanjay is a good teacher and he teaches a lot. So if there are any questions, then you should feel free to ask.
Yes, sir. Apart from residents, sir, Prashant Jain sir is there, Dipti Sharma ma'am is there, and that's all
Yeah.
there. Yogesh Tiwari sir is there,
I'm sorry.
and also yes, sir.
Hello.
Hello, sir.
Hello. Yeah, just wanted to ask your opinion regarding skin sparing mastectomy, especially in young females, wherein they present with a large tumor and on presentation they are lymph node positive also.
Hmm.
In which subgroup of patients do you offer skin sparing mastectomy followed by LD flap?
Thank you, sir, for that question. I was going to put up slides for skin sparing mastectomy, but I thought it'll be too much, and Sanjay agreed, so I didn't add them. So skin sparing mastectomy, um, we only recommend if we are doing some form of immediate reconstruction. And as you said, LD flap is, I know, one of the most commonly used and workhorses in India. Um, Patients who've got extensive disease or large tumor footprint, um, which is not amenable to conservation, if it's a very spread out cancer, or even for sometimes even for DCIS, we do skin sparing mastectomy. But here, the LD flap, unlike India, is the last option. So they would either opt for an implant based reconstruction, or they would go for um, a microvascular flap like a DF flap, um, or a thigh flap, gluteal flap. So the LD flap is only a fallback option in the UK, but I know in India, LD flap is the most commonly done flap. So any indication for mastectomy, if it can either be a nipple sparing or a nipple sacrificing mastectomy. And then we can do an LD flap. It's very useful if you need to sacrifice some skin. So if it's a central quadrant tumor, which is involving or close to the skin, but the patient wants reconstruction, then it's a good option to preserve whatever skin you can, do the axillary clearance, and then swing the LD into the skin using some of the skin from the back. I think those are the options that we would use LD flap for. But here, as I said, it's quite low down in the options because they don't want to waste the LD flap. It's a very robust flap, and it does very well. It heals very well, but it causes a lot of functional problems for the patient, especially a lot of patients here enjoy swimming and exercise and Pilates and those kind of activities. So they want to preserve as much function as they can. So they prefer implants or they prefer a microvascular flap, which is cosmetically better than LD or implant. So those are the situations.
And how do you people manage patients who come with phylloids, big size phylloids? Therein, what is the reconstruction algorithm?
So with phylloids, again, here we don't see the phylloids that we see back home. A lot of them would have just a wide local excision or a breast conserving surgery, even with phylloids. For very large ones, most of us would restrict ourselves from doing an immediate reconstruction because with phylloids, the margins and the classification of it, whether it is benign, borderline, malignant, those are the things that we're worried about. So you would wait for the histology to come back. I think I would just offer a simple mastectomy if it is a very large one or very close to the skin. And then bring the patient back for a delayed reconstruction once she's had her adjuvant. Sometimes they need radiation and other treatment. So once they've had that, maybe 2 years down the line, we would offer delayed reconstruction. But as a rule, just going back to your first question, as a rule, any patient who is having a mastectomy here, whether it is skin sparing or a simple mastectomy or a nipple sparing mastectomy, reconstruction is always offered to the patient. They can choose not to have it, but it is always offered. So the option of any reconstruction, whether it is LD or implant or a flap, would always be offered to the patient, irrespective of what surgery they are having. Exceptional cases are, as I said, surgery for phylloids, which is very large and we're not sure if this is malignant and may need radiation, or it could be inflammatory breast cancer where we would keep things simple, or it could be a patient who has very high medical comorbidities, like very poor functional status, elderly patient. You want to do the quickest surgery possible, then you would just do a simple mastectomy or sentinel node or axillary clearance, whatever it is, and come out and not stand there and do a reconstruction, whether it is implant or LD or anything. So I think those are the patients, and especially smokers. So that's again not a problem in not so much in India, but here smoking is absolute contraindication for offering even local perforator flaps or implants, or even if the patient is very insistent, we give a very high risk of complications because smokers, they just lose the implant, they lose the perforator flap dies. Even the DF flaps, the plastic surgeons outrightly refuse if it's a chronic smoker or active smoker. So I think those are the contraindications.
And in phylloids, what is the definition of wide local excision? Do you take the muscle pectoralis major routinely, or you spare it?
No, we don't take the muscle routinely, but margins is the so it should have I think it's a 5 millimeter margin for phylloids, if I'm
That's
not
what
wrong.
I'm asking. So are you removing from the pectoral fascia or taking a cuff of the
So
muscle as well?
No, we go up to the fascia. But if it is clinically involving the pectoral muscle, then you would have to remove it. But if there is no pre-op, like on the imaging or intra-op, if there is no suspicion of muscle involvement, then we wouldn't routinely remove the muscle. It'll just be up to the fascia.
And just for the sake of the residents,
Mhm.
what is your policy regarding the fibroadenomas?
So fibroadenomas usually will not be offered surgery unless they have shown a significant increase in size or a sudden increase in size. Most of the fibroadenomas would be discharged, so they would, after the age of 25, they will have a biopsy to prove that it is a fibroadenoma and it's a benign fibroadenoma. And then they would just be discharged back. They don't come back for surgery or routine follow-up. If again, if there is a rapid increase or if there is a change, or if there is a change on imaging or clinically, then they would be offered surgery. Or if on core biopsy there is a suspicion of, say the report says fibroepithelial lesion, but they're not committing to fibroadenoma or phylloids, then we would offer excision, and it would be more like a diagnostic excision. So when you operate on such a patient, you will not go with the intention of taking very wide margins. You would just do a standard excision, and if the margins are closed or it comes back as phylloids, then the patient goes in again for a re-excision of margins. Otherwise, we don't operate on phylloids.
So I think it was an excellent talk, and
Thank you, sir.
thank you for giving us your time. Yeah.
Thank you.
Hello, Coach. Yes, Dr. Deepti Sharma. Very
Hello,
nice talk,
ma'am.
elaborative presentation.
Thank you.
And like the words say that we have to unlearn so many things for the new learning. With such a constantly changing trends in the West cancer
Yes.
management. Okay. Thanks again.
Thank you, ma'am. Thank you.
Ma'am, this is Dr. Yogesh Tiwari, ma'am.
Hello, Dr. Tiwari.
What,
Hi.
ma'am, how you treat the mastalgia patient, ma'am, in your setup, ma'am? What is
So mastalgia depends on the age. Anybody under 40 years. So here the pathway is slightly different. Some units have a mastalgia clinic or a breast pain clinic, which may not be run necessarily by a surgeon or a doctor. They have physician associates or nurse practitioners who do either a telephone clinic or see the patient in clinic, and they would assess the patient first. So it's slightly different here. Some patients come directly to the surgeon's clinic by a referral from their physician. And that would be either at the level of the physician, they have ruled out usual causes for mastalgia, like it is non-cyclical mastalgia, not responding to analgesics. They've tried conservative treatment like adequate breast support, getting new or measuring the bra size and getting a new support for a good number of time. And they have other symptoms, say if they've noticed a lump along with the pain, or the pain has persisted beyond the cycle, or it's a new onset pain, or if it's an elderly patient and they suspect that they want to be screened for cancer, then they would refer the patient and then we would see. Most of the times, it would just be, if it is over 40, we would do a mammogram. And if there's no concerning findings on the mammogram, then we discharge the patient with general advice on breast pain. We don't routinely prescribe evening primrose or vitamin E or ask them to restrict tea or coffee, unlike the practice in India. There is a pre-printed leaflet that we provide the patient, which has all this general advice that I've just said. And it also talks about other causes of breast pain or non-breast related mastalgia, which is teeth syndrome or costochondritis or musculoskeletal pains or fibromyalgia. So just educating the patients, telling them about being breast aware and breast examination, and if anything changes, come back. But we mostly rely on topical pain relief like ibuprofen and diclofenac gel, and those kind of interventions. otherwise we just discharge the patient. They won't be under regular follow-up. Anything under 40, if the clinical examination is normal, then we discharge the patient with the same advice that I've just said. If there is anything concerning, or if there is a lumpiness, or if the GP's found, or the physician's found something, or the patient says something, or if you find something on examination, they just do a targeted scan. So only that particular area on that breast would be scanned. They will not do a whole breast ultrasound. And if there is no concerning findings, then you just discharge the patient. They won't be on regular follow-up. Post-op cases with chest pain or mastalgia who've had surgery would be referred to a chronic pain clinic if it persists for a longer time. Otherwise, it's just symptomatic treatment.
Ma'am, another question, ma'am.
Sure.
After breast conservative surgery, how you apply clips, ma'am, for the radiation oncologist, and how it's necessary, whether or not, and after
Yeah,
transposition of flaps, what is the status of clips, ma'am?
Yeah, I think it is very important to place the clip, especially if you're doing if you're doing a mammoplasty or a transposition or a flap, because the oncologists need to know where exactly the lumpectomy was, because once you fill the cavity with tissue from the chest wall, they can't really be sure. So clips is very important, and we are no longer relying on the seroma. So we place clips as a routine. Of course, somebody who will go for a whole breast radiation, which most patients do, it is all right if you've forgotten. So we don't panic if you've forgotten to put clips. We panic, but we speak to the oncologist and we say this is where the tumor was, and you have a discussion, and they're fine. But routinely we place clips. Again, just like India, there is no standard way of putting clips. Every surgeon here has their own way of putting. I've seen people put it in two planes. They put it close to the chest wall all around, 4 quadrants. Some people just put it on the center where the tumor bed was, on the pec major or the chest wall. Some people put it in two planes, one on the chest wall and one in the more anterior aspect of the breast, in just to get an idea of, just like sir was saying, it's a 3-dimensional structure, so putting it in two planes or in a spiral form gives the oncologist an idea of where exactly the tumor was in a 3 dimension. I usually, depending on the breast volume, if it's a very large volume breast, I put it in two planes. So that'll be 8 clips at least, just to get an idea of the 3D contour of the breast. But if it is a small breast and not very high volume, then I would just put it in one plane, either anteriorly under the flaps in the tissue, or I would put it on the chest wall.
Okay, thank you. Thanks a lot, ma'am.
No problem.
I think there are no more questions or comments. So again, thank you so much, Gunj,
Thank you,
for
Sanjay.
taking out time. I know that you are busy this week and you are still doing this from your clinic only. So thank you.
No problem.
Yeah.
It's my pleasure. It was great. It's always great to connect with people back home. It's always great. So thank you for having me. And thank you to all the seniors who joined as well.
Yeah, thank you. And also, we would like to have you here in person. Whenever you are planning to come, then
Of course.
definitely we can plan something.
Of
So,
course. Yeah, my pleasure. I'd love to visit.
okay. So, thank you, everyone.
Thank
And
you.
yeah, thank you. Good night, everyone. So, we will meet on this Saturday for our monthly physical meeting. So, I will be announcing that. Thank you, everyone. Good night.
Thank you. Good night.